this week on the BackTable podcast.
I usually tell the patient exactly what I'm going to do and the reason, the purpose behind my exams. I tell the patient,
important.
I tell the patients that, I'm going to palpate different regions in your pelvis. I want you to tell me whether I reproduce your pain or produce a different kind of pain altogether. The better, I can, reproduce your pain, the more likely I can help you, and I also tell them about, I perform a rectovaginal exam on all my patients with pelvic pain, essentially. It's not something that everybody does, so for them, it's like the first time for them to have rectovaginal exams. So I tell them exactly the reason behind that I do the rectovaginal exam. I tell them that, that the most common site of endometriosis is going to be in the cul-de-sac uterosacral ligament, and it's a lot easier for me to access that area with a finger in the rectum.
Hello, everyone, and welcome to the BackTable OBGYN podcast, your source for all things obstetrics and gynecology. You can find all previous episodes of our podcast on Spotify, Apple Podcasts, and on BackTable.com. This is Mark Hoffman, and I'm here with a friend and incredible guest, Dr. Ted Lee. How are you, Dr. Lee? Can I call you Ted for the show?
Please. Thank you. Yeah. Once you're not fellow anymore, you can call me Ted.
So for our listeners, Ted is a legend in our field of MIGS, minimally invasive GYN surgery. He is a clinical professor of OBGYN at McGee Women's Hospital, UPMC in Pittsburgh. He is the director of the Division of Minimally Invasive Gynecologic Surgery, past president of AAGL, has won the Golden Laparoscope Award there, I think, 6 times. Is that right, Ted?
Yeah, I haven't break Tom Brady's record yet.
Well, I think if they haven't already, the award should be named after you. Is that in the works?
I don't think so.
I'll work on that.
Yeah,
and also a member of the board at SGS, the Society for GYN Surgeons. So, Ted, thanks again for joining us on the show.
Oh, thank you, Mark. Thank you for having me. I'm very honored to be one of your guests.
No, we're excited, and this is a continuation of a conversation we had actually at SGS about things to talk about in the show. But one thing you wanted to talk about, which I think is an extremely important topic, is like the ambulatory workup of endometriosis for patients in whom we suspect endometriosis. But before we get started into the topic, tell us a little bit about your practice, how you got to be where you are, because I think those of us who did the AAGL MIGS fellowships, it was sort of set up for us in ways that maybe not everybody had that. So talk to us about your current practice and how you got to be where you are.
Yeah, I think I kind of fall into what I do currently, accidentally, to be honest with you. When I was a resident, I think obviously laparoscopic surgery at that time was very, very uncommon in academic OBGYN residency programs. And you probably don't know this, laparoscopic surgery in our field was started in people in the private sector. And it's virtually nobody in the academia that is teaching laparoscopic surgery. So when I was a resident, my exposure was basically vaginal surgery. I had a very good mentor, Dr. Terry Gordy, who has obviously since passed, was very well known in the vaginal surgery world. And then I thought when I finished training, that would be something I wanted to do. At that time, and it was only probably a handful of year gyne fellowship. And then I applied and I didn't get the position. And so I started out my job as a brand new faculty practice in a small OBGYN residency program in Baltimore called Union Memorial Hospital. It's like next to the Hopkins undergrad campus. And during that year, I wasn't busy. I had only about 2 or 3 patients, half-day session sometimes. I had like nobody because it's a brand new practice. I had nobody. I didn't know how to get patients.
And this was a generalist practice, obstetrics and gynecology?
Yeah, we have like 2 or 3 residents a year. Obviously, the residency no longer exists at this point. And then, so I was kind of like, feel like I'm wasting my life away. I want to do surgery, and I wasn't getting any surgery. I borrowed a bunch of slides from Terry Gordy at the time, was teaching the residents about vaginal surgery, sacrospinous ligament fixation, and so on, but I wasn't doing any surgery. So I feel like I just feel like this is not going anywhere. So, and that was the year I learned how to fly fish because I have so much time.
Something good came out of that for sure.
Yeah. So I had a lot of free time on my hand, and then how to fly fish, and then I learned how to tie flies. during that same year. So one day I opened the OBGYN news. I don't know, most of the audience, the younger audience these days doesn't even know what OBGYN news is. It's basically actual newspaper basically that give you the information on what's going on in the OBGYN world. They will have summaries of different meetings. And in the back of the OBGYN news, there's always some advertisement for some job positions. And one day I opened it up and it was this fellowship with Tommy Lyons and C.Y. Liu, both of which are they are both pioneers in our field. Initially, it was supposed to be a combined fellowship, but each one ended up taking their own fellows at a different time frame. So I ended up becoming fellow with Tom Lyons.
And he was in Atlanta, is that right?
Atlanta, yeah, he was in Atlanta. Yeah. If you guys don't know, he used to play professional football at Denver Broncos.
It's one of the most interesting biographies I've ever read in my life. I think he was like a concert musician too, and like led the Denver Philharmonic, I think, at one point while he was a member of the Denver Broncos. And didn't he?
He was going to medical school at the same time too.
Yeah. It's just these people are made of different stuff than I am. It's amazing.
Yeah.
So, and oh, by the way, he's a pioneer in gynecologic surgery.
Right, exactly. He was a big proponent of laparoscopic supracervical hysterectomy. Back, at that time, he could do a total hysterectomy easily, but he really kind of believed that if a patient doesn't have any pathology in the cervix should be kept. So that was kind of, and then he was the first person I realized that how beautiful dissection in laparoscopic surgery can happen. And I also spent a lot of time with C.Y. Liu because back in those days, they were the big shots, right? They are like invited to meetings all over the world. So one of them is always traveling somewhere. So whenever time is traveling somewhere in Greece or Italy or somewhere, I would drive up to Chattanooga and watch C.Y. Liu operate, and vice versa. So I learned a lot.
What an amazing opportunity!
Yeah, and it was kind of very strange because apparently when that position was posted, there was over 100 applications for one spot.
Wow.
I was obviously very fortunate. I don't know how I got chosen. The only thing I can think of is that I share the same birthday as Tom Lyons, and we have the same initial.
Whatever it takes. I mean,
whatever it takes,
I think.
Yeah.
But no, I think it's always fun for me to start the show with understanding how people got to be where they are. To think what a loss to MIGS it would be had you matched into Eurogyne.
Yeah, it was meant to be.
Yeah, it wasn't your favorite day, but it was a good thing for patients with endometriosis and for the MIGS specialty as a whole. So you were with Tommy Lyons and C.Y. Liu for a year?
1 year. Back then it was basically apprenticeship. Back in those days, it's like the kind of like the fee for service, those people in private practice are rock stars of our field. They were basically getting paid fee for service for everything, not just for endometriosis surgeries, everything. They get fee for service. So, I was fortunate to he allowed me to perform some of the surgeries. And I also practiced a lot on my own. And I was his first fellow, so he didn't know what to do with me, to be honest. And I was practicing a lot on my own. So he has a back room where he has like a TV monitor. And so I construct my little pelvic trainer that's made of a copy paper box with a lid. And I put trocars on the lid of the paper box. And I carve out the end of the box. And I use the colposcopy light as my light source. And I put the camcorder that was the gift from my in-laws, and I put on a tripod and I connected to the TV monitor, and that was my pelvic trainer. And I would be basically getting the chicken thigh, get all the fat of the chicken thigh, debone the chicken thigh all laparoscopically, and then close the defect of the chicken thigh once I debone the chicken thigh. And that was basically kind of my training, my pelvic trainer, and it comes in handy. So when he handed me, the tools, and I was able to jump on and do laparoscopic birch perivaginal repairs without much prompting, because I was pretty good at suturing by that point on my own.
That's something that I talk to my residents about a lot is, I think when we're teaching open surgery, most of us know how to hold a pen, holding a knife and retracting. There's skill there, but I think we're used to using our hands. What I want our residents to show up to the OR with is the ability to use those instruments as as extensions of their hands. That's something that you can do in the lab, like you did with the cardboard box. That's something I did with a cheap trainer in a closet up by the post-op floor, just throwing stitches and just tying knots and just doing as many of those kinds of little dexterity things. So when I got to the OR and had an opportunity to operate, I could learn how to operate, not how to hold the instruments. And so that's
exactly
a perfect example of how someone can make the most of their opportunity in that situation. So
right.
So you were with Tommy Lyons. You were there for a year, and then did you go straight to Pitt after that?
No, I was it also at that time MIGS wasn't a thing. Most academic departments doesn't know what MIGS is. And so I finished, I was getting close to finishing my fellowship. I sent out maybe over 100 cover letters to various OBGYN chairs in the country. And I think I heard back from like 3 or 4 places. Okay. And so the first place that offered me a job was Medical College of Georgia. Because, Tom is very famous and people in Georgia respected him. So I got a job offer there, and then I interviewed at Wake Forest, and I interviewed at GW, and GW was where I went. That's my first job after fellowship.
Okay.
Yeah.
And how long were you there?
I was there for 2.5 years. 2.5 years. Yeah. And so when I started there was, what I do is, I think most people can consider me as like a threat because I'm the kind of steering up the status quo there. And there's a lot of people, people just at that time just kind of like don't want you to succeed, basically. And they just have to prove them wrong, and you get better and so on, because people want to pick on you when you first start, especially, back then, laparoscopic surgery just wasn't so common. And so, yeah. And then also when I started, I still had to do OB calls. I was doing a lot of OB calls.
I did too. It's nice to see all these jobs that are being posted now for MIGS fellows. It's not, it would have been nice, but it's folks like you that laid the groundwork for the rest of us to follow.
Yeah.
And then from there it was Pitt.
Was Pitt, right? So so at that time, towards the last year of my tenure at GW, they were having some financial troubles, and I just kind of opened the back of the Green Journal. At that time, I had been always doing a lot of urogyn procedure laparoscopically, even when I was at McGee. So when I opened the back of the OBGYN journal, they have a position posted for urogynecologists at McGee Women's Hospital. And I just applied. I also applied for a position at Yale at that time. But the McGee replies that, well, that position has been taken, but your experience is very, very different. And my chairman still want to have you come in and interview you. So,
who was the chair at the time?
Rick White. He's an infectious disease expert originally from the University of San Francisco.
Amazing how much a leader with vision can make an impact and get someone like you to come and give you the space to grow and build something when most other people in that situation, in that seat, did not. I love hearing the story of how you got to where you are, because it's never the straight shot. It's almost never just the straight shot.
Yeah, it's a very very circuitous. That it's not like a direct straight line. Yeah.
So the other thing I wanted to ask you before we get into endometriosis related, but before we get into the workup, I think as a fellow who also went somewhere after training where I was the only MIGS person and there wasn't anyone really doing what I did, I found endometriosis surgery to be the toughest thing to learn how to do. And I still feel like I have so much to learn, watch your videos and talk to you about this and your colleagues and those who you've trained. How did your interest, your skill set, your ability to take care of those complex endometriosis patients, how did that come to be? What did that look like in your early career?
Yeah, I think in the early career, I was obviously still learning. I think to get to where I am, obviously took many, many years. And also back in those days, there wasn't YouTube, there wasn't any kind of things that you can watch online. So everything is you go to meetings and you see how the people does it, and you're trying to go back and to see if you can do it and so on. And that's how it was in those days. So when I started, it was basically, I remember like when I was at GW, anytime I get into trouble, I had my good friend oncologist come in and help me. And usually if I have to, if endometriosis is so severe, he will come in and open the patients and he would do surgery with me. Obviously that in those early days, that's how it was, and then you learn and you get better. I think what got me interested in is like not even patient with severe endometriosis, and actually patient who has actually relatively straightforward endometriosis surgery, relatively straightforward excision. And patient has seen many doctors and have many procedures done, and they have no improvement of their pain. All of a sudden, you come in there, you find endometriosis, you cut it out, and they are pain-free. And you feel special. You feel you can do something that other people cannot do, and then you keep on doing it. And I think that's how it all got started, is just because just a few patients that you feel you can make impact on, give you that motivation to continue to do more. And then as you get better known, then you get fed a lot of worse and worse cases. And then you kind of either sink or swim, you get better and figure things out. And then, that's how it works. And I think a lot of times is, I consider myself very, very fortunate that I was able to take care of a lot of complicated patients early on in my career without, causing too much complications, and be able to learn.
No, it's a tight line to walk. I mean, I had that experience in many ways, and actually was at a different hospital than our GYN oncologist. And so it was urology, it was colorectal for me for some of these bigger, tougher cases. And I'm very, very grateful for the partners that I had, that work with me, but also, I mean, you get into too much trouble early on, that can be the end for your career in that place. And so it's a tight rope to walk for sure. Yeah. But for all the surgery we could talk with Ted Lee, one of the things that I was surprised that he said he was interested in talking about the ambulatory workup of endometriosis, but it's also, I think, one of, when I talk to residents about or trainees about, being a surgeon, I always focus on the clinic workup, the ambulatory workup, the decision for surgery. That's what I think really makes the doctor. I think you can train a lot of people to do procedures, but the decision to go to the OR. So what is it about endometriosis, before we get into the sort of the steps you take, what is it about endometriosis that is such a diagnostic challenge? Because it is, right? It's, years, 7-8 years before people get diagnosed. What is it about endometriosis that makes diagnosing it so difficult?
I think, there's always the stigma of pelvic pain. I think a lot of people, whenever, they're busy practice, you have many patients waiting in the waiting room, and then you flip the chart and look at this patient's chart, say, oh, pelvic pain. And then, automatically, a lot of people are just thinking that, well, it's pelvic pain, it's going to take a lot of time. And so they already have like kind of a built-in prejudice, already about the patient. And that's one of the obstacles that the patient faces, is that the physicians themselves just don't feel comfortable asking questions and taking care of this type of patients. In reality, is once you have done this long enough, it's a lot of the questions become very automatic. Nowadays, if you have Epic, you can have like basically a smart phrase or smart text, basically all the prompting questions that prompt you to ask. And you can do that very, very easily. Back in those days, for me, it was just automatic. That's what I ask, and it's, and the answers I get. But once you're comfortable with it, the history part of the whole encounter, it's pretty straightforward. And everything's practice. If you do enough, then it won't take as long.
My guess is most of the patients, or many of the patients that you're seeing, are patients that have already been diagnosed with endometriosis, and then they get referred to you. Is that true, or are you getting a lot of patients that are just coming in with pelvic pain? Or
I have patients who has seen so many doctors already and who hasn't been diagnosed. So recently, I was shown a video of a patient of mine that was doing like basically the video was recorded so one of the PhD students can convince the people who give out grants to give her the grants for like AI diagnostics for endometriosis. And it was a project that Nicole Dinellen, one of my associates, was working on with a PhD student. And so this was obviously after they recorded and they showed it to me. And it turns out like the mentor for the patient for the PhD student turned out to be the husband of this patient.
Oh wow!
Yeah. So I was like, how did Dr. Dinella know about my patient? And so it was kind of strange, So, but anyhow, so they showed me the videos, and it was this patient who I met for the first time in her late 40s. And she'd been having pelvic pain for many years and had four rounds of IVF all failed. And I examine her and look at her ultrasound. I say, you have stage 4 endometriosis. She has, like tethering and nodularity on exam. And then when I heard about the IVF that she did, the full IVF she did that failed, I feel really bad. I said, I wish I had met you earlier. So not all my patients were diagnosed. Actually, a lot of patients are not diagnosed with endometriosis. They've been diagnosed with many different things. They have been diagnosed with interstitial cystitis. They have diagnosed with bowel syndrome, everything else but endometriosis.
I mean, for those of us that do it, those are red flags, right? Those, IBS, IC, chronic pelvic pain. It just jumps to the top of our list because I think we see it a lot. But I guess when you're not doing this a lot, it's not something maybe that's high enough on your differential.
A lot of our patients are given diagnoses they don't have a lot of times, and so I have patients who have supposedly to have interstitial cystitis, and I palpate the anterior vaginal wall. She's not even tender there. Typically, patient with interstitial cystitis, you palpate the anterior vaginal wall, do a subpubic, compression. They will have severe pain, but a lot of those patients don't have those kind of exams. And so there are a lot of patients being diagnosed with all kind of problems, levator spasms, IC, irritable bowel. And then and I do an exam and I touch their cul-de-sac and uterosacral ligament and they jump off the table. That's the kind of exam, they have instantaneous reaction to the exam. What I call is very like a visceral reaction to the exam. That's a classic visceral reaction. That's how I term it, how I kind of describe it.
Yeah, you can see it in their face. Yeah,
it's something that they cannot fake,
Yeah,
it's just what I call a very authentic exam. And those are the type of patients I know I can help.
To begin your workup, now we could start in clinic, but a lot of folks will have like surveys and stuff they send out. Are you guys sending out packets or surveys to patients prior to them coming to clinic? Does the workup begin when they come into your office?
Yeah, I think the problem with surveys sounds great. The problem is like nobody look at it a lot of times.
I think that's very true.
I mean, I think you need to have resources to have like a nurse practitioner or PA to screen, or somebody to screen those surveys. And I think it can be incredibly helpful. Unfortunately, most people just don't have the time to go through the surveys. And I think it could, ideally you really could use a survey, but ideally most people don't.
So it starts with an H&P for you. It starts with
exactly.
Just, get a thorough history. And I think that's something about what we do that is extremely valuable. And like you said, I think it's the first thing we learn as med students. I don't think it's gotten less important, even with all the technology that we have. So in your history, what are the types of things you're asking that maybe not everybody is asking? So obviously, G's and P's and other health history, but what are the things you're looking for in patients in whom you suspect endometriosis?
Right. Well, I mean, obviously the age is extremely important, so if you have a patient coming at age 50, and have pelvic pain for the first time, you're not going to think endometriosis, right? So, age, the patient presented to you, obviously, they can tell you, older patient in their 40s, they will tell me, I have severe pain with my period since my teenage years, So those patients, even though they present late, they can still have endometriosis because the onset of the symptoms was many, many, many years ago. I think gravity parity is important too, because a lot of times, for example, if you are doing hysterectomy for fibroid and the patient G0, P0, right? And it should not be assumed that just the way it is, because most people are going to be pregnant unless they purposely try to avoid pregnancies. So if they come in G0, P0, you have to ask, well, you just don't want to have kids, or have you tried, using kind of birth control? If they tell you, I just never used birth control and never got pregnant, and that should be a red flag.
That's a good one. Yeah, it's interesting.
Yeah, and it's something that it's something that you need to keep the back of your mind. In terms of the G's and P's, I think C-sections, vaginal delivery and stuff like that, it's important, especially with C-sections. A lot of patients with C-section end up with endomyosis, and the other thing that can happen with C-section is abdominal wall endometriosis.
I see a lot of that. Yeah. I think my reflex to think about that is or my threshold rather to think about that's pretty low. if they're having pain at the scar apices, and it gets missed a lot.
Well, a lot of times abdominal endometriosis are not even near the C-section scar. Sometimes they could be like maybe a few inches or even, close to, like removed from the actual C-section scar. And then the ones that get missed a lot, the subcutaneous ones that people can pick up because sometimes you'll feel that, in patients. The one that gets missed a lot is like rectus muscle endometriosis, like subfascial endometriosis, right?
Yeah.
Those you don't feel a lump, you palpate the area, they would have tenderness there, but you don't actually feel a lump because it's subfascial. And in those patients, they'll frequently tell you the symptoms of, pain with coughing, pain doing sit-ups, that's worse with their period, stuff like that. In those patients, I would just order MRI, and a lot of times they will show up with rectus muscle endometriosis.
Yeah, and I want to go through your imaging modalities to work up here in just a minute, but because I think there's a lot of variability, but I have a pretty low threshold for that as well. But
in history, I think your typical things are 3Ds, right? Dysmenorrhea, dyspareunia, dyschezia, very very kind of typical symptoms that you ask. I think if patients does not have dysmenorrhea, as long as they're having menses, okay, then this, I think it's, dysmenorrhea is the most common, the most basic symptoms of endometriosis, unless they become amenorrheic for different reasons, right? They're on some kind of, hormonal medication make them amenorrheic, but most patients with endometriosis, like I said, like almost all of them have dysmenorrhea. Dyspareunia, dyschezia are much more, patient can go without it. Yeah.
And I tend to think, and I don't know that I have the evidence at the tip of my tongue to support it, but I think about endometriosis in terms of progression. So like you said, starting off when they start having periods, a lot of times they had painful periods with menarche or shortly thereafter. They got put on birth control pills, whether it's because they were becoming sexually active or because their doctor said, you're having painful periods. Let's see if we can't improve that. And they do better for a number of years. And then sometime in their 20s, they're like, I'm tired of being on birth control pills. Or they're taking off birth control pills because they're going to try to start a family, and all the symptoms return.
Right.
And that to me is like a telltale sign. Like, okay,
yeah,
when you were being treated, symptoms went away, and then it got a whole lot worse. And the longer they're kind of off treatment, the worse it gets, and the more difficult it is to put them back on hormonal suppression to treat it. And that's oftentimes like when they get put back on and they fail, that's when they get sent to me.
Right.
But yeah, I agree. I feel like it starts cyclic. All the other stuff down the road, the daily pelvic pain worse throughout the day with activity, the musculoskeletal component, IC, IBS, kind of the three-headed monster with endometriosis, that seems to be a later progression. Do you feel like that's what you're seeing as well in your patients?
Yeah, I think so. But I think a lot of times, initially the pain maybe is just during their periods, and over time they would have pain outside their periods, and typically still worse with period. Usually worse also during mid-cycle too. That's kind of very common kind of report.
Like ovulation pain.
Exactly, yeah. And also, one of the things that I tell other people is that, say if patients have lateralized pain during their period, that is a very important piece of history because that...
Explain what you mean by that lateralized pain. Like it radiates?
No, if they say, I have right-sided pain during my period, or I have left-sided pain during my period. Yeah. Not like just pelvic pain. If they can say, I have very, right-sided pain or left-sided pain. Of course, a lot of patients with endometriosis have midline pain too. But if they tell you that they have right-sided pain or left-sided pain during their period, that is very, very indicative of endometriosis. Yeah.
So you have a patient that you are suspicious of. And I think, and I use the term in whom, a patient with suspected endometriosis or presumed endometriosis, because I think we talked a little bit about the delay in diagnosis. I think part of that is undoubtedly, we got to believe women, we got to believe patients. It's chronic pelvic pain. It's a challenging condition that can overlap. But I do think part of it is also the fact that this is a disease that is diagnosed, at least currently, it's a disease that is diagnosed surgically. So we'll have patients that I presume have it, or in whom I'm highly suspicious that they have endometriosis. But if they're doing well on birth control pills, or we find some other, non-surgical management that works for them, we don't necessarily have to diagnose. Do you, or at least that's how I've been practicing. Are there patients that are you always starting treatment with hormonal suppression of some kind prior to surgery, or how quick are you to go to the OR?
Yeah, I think it depends. I think one of the barriers for diagnosis is frequently physicians are not comfortable of taking patient to the surgery. And one of the reasons, the barrier is they are not sure if the surgery is going to help or if they're going to find anything. And so I think one of the ways that for me is I'm very confident with my history and exams that allow me to offer that a surgery as an option to the patient a lot more frequently than other people. I think if you are not sure whether the patient is, having endometriosis, or you're not even sure if you're going to be able to help the patient surgically, you're less likely to offer that as an option.
Right. Physician comfort in managing a problem is definitely going to push you one way or another in terms of what you're going to recommend.
Right, exactly. And of course, always do no harm, right? That you don't want to do something that you don't have the training or the skill set to perform and hurt the patient. So, I totally understand that. But I think one of the barriers is that people in general just don't feel, comfortable performing surgery. And that's one of the reasons. And actually, one of the other reasons that I think most people don't think about is the patient themselves as part of the delay for the diagnosis, because they write things off. They think it's
people
normal.
Get busy. People have lives. Yeah, or they don't know. That's right.
They think it's normal. They say, "Oh yeah, I miss work all the time. I miss school whenever I have my period," and then I just thought that was normal, And then I tell them, "No, that's not normal," And
and sadly, a lot of patients that I see, their doctor said, "Well, that's just the way it is," or their mom or family or somebody has just sort of told them this is the way it's going to be or it's supposed to be, and that's it's sad to hear that. But yeah, so listening is a huge part of diagnosis. Trust patients, believe them when they tell you something's wrong. Believe them, and they oftentimes have been through many things. But so you've got a patient, you're suspicious that they have endometriosis based on a history. Touched on it a little bit. What are the exam findings that make you think a patient is more likely to have endometriosis, less likely to have endometriosis?
I do, obviously, see the patients, obviously see how their general behavior is and everything, before I even start the exams. I usually tell the patient exactly what I'm going to do and the purpose behind my exams, I tell the patient,
important.
Yeah, I tell the patients that, I'm going to palpate different regions in your pelvis. I want you to tell me whether I reproduce your pain or produce a different kind of pain altogether. The better, I can, reproduce your pain, the more likely I can help you, and I also tell them about, I perform a rectovaginal exam on all my patients with pelvic pain, essentially. It's not something that everybody does, so for them, it's like the first time for them to have rectovaginal exams. So I tell them exactly the reason behind that I do the rectovaginal exam. I tell them that, that the most common site of endometriosis is going to be in the cul-de-sac uterosacral ligament. And it's a lot easier for me to access that area with a finger in the rectum.
So are you feeling for big nodules, or are you feeling for nodularity? Just like, is it pretty subtle sometimes, the findings on the... Most
of patients don't have nodules. Most patients with endometriosis are not going to have nodules. Nodule is a sign of late disease, and it's obviously, when you feel nodules, that deep infiltrated endometriosis. So the majority of patients are just going to have localized tenderness in the area. So usually most people don't know how to do rectovaginal exam. And obviously this is a podcast, so people have to use their imagination to see how I do the exam, okay? So I have one finger, my index finger in the vagina, my middle finger in the rectum. I have my middle rectal finger palpate anteriorly until I feel the cervix. Cervix is a very reliable landmark you can feel on rectal exam because it's firm, okay? And we all know that uterosacral ligament is there behind the cervix. So on either side of the cervix will be the uterosacral ligament. So if you sweep it laterally and posteriorly, that will be your uterosacral ligament. And whatever is in between is it's the cul-de-sac. So if you touch that part of the pelvis and you produce the pain, that the reaction that I describe as a visceral reaction to the exam, I feel pretty confident that this patient very, very likely would have endometriosis. That visceral reaction is something that you cannot fake that part of the exam. Obviously, with pelvic pain, there's always a lot of, drug-seeking patients who, want to, get medication from you. But with this exam, it's very specific. And if everything hurts, typically I don't feel confident the surgery is going to help them. Needs something beyond surgery, right? If everything hurts. They may have vaginismus.
So you're looking for more localized pain at the uterosacral ligaments, at posterior lower uterine segments, a place I feel like we feel it all the time.
Yeah, mostly just posterior cul-de-sac, uterosacral. So I can also feel like tethering. If there's like scar tissues in there, I feel some tethering. And if they have very small, like what I say, granular nodularities, like little rice grains in the area, I can feel that sometimes as well. Obviously, the big nodules I can feel. So those are what I do with the vaginal exam. But before I even get to that part, I usually palpate the anterior vaginal wall. That would be the first thing I do, unless I have know the patient have interstitial cystitis. If I'm very strongly suspicious, patient might have interstitial cystitis. So I do like 1 digit or 2 finger exam on the anterior vaginal wall. You just start out first, unless I strongly suspect that patient might have IC. Because if patient IC touch that part first, then the exam is done basically. So those patients I don't start anteriorly, but in general, for most of my patients, I start anterior vaginal wall, palpate that area, palpate the levator, obturator interest muscles, just for focal tenderness. Patient might develop myofascial pain. I used to do a lot of injections in the muscles, but a lot of times, in my experience is that the muscle spasms and pain tend to be reactionary to the disease. And so if you treat a disease that you would treat the patient. So a lot of injections that you make some temporary relief, but their pain will come back.
The analogy I use for that, and I do the same thing. I mean, if you hold a gallon of water for a week, I can take the gallon of water away, but your muscle's still going to be hurting for a while. So occasionally we can address the initial insult. At times, though, the muscle pain that was associated with it may continue, and there may be opportunities for improvement with PT. But I agree, starting with the insult, the initial nidus of pain that led to that musculoskeletal pain, you address that first and then see what's left over. I think that's a common thing. Are you starting your exam with the back and the belly, or are you going straight to the pelvic exam first, or do you
I just do the, obviously I just inspect the abdominal wall initially, especially in patients with C-sections, and I'll palpate into the vaginal wall. Most patients with endometriosis, unless they have abdominal wall endometriosis, typically abdominal portion exam are quite non-tender, okay? And so I always kind of like, I suspect something is not quite right when patient, like you barely, put your hands on the abdomen, they are like having so much pain, those patients, sometimes you're not sure if it's endometriosis related or something else. And so after I anterior vaginal wall, levator and muscles, and then I touch posterior fornix. So in patients who have endometriosis, if you like lift the cervix, try to do cervical motion tenderness, if you stretch the uterosacral ligaments, they're gonna have pain with that as well. Okay. So and then I do the rectovaginal exam, the last part, because that's the most kind of difficult part of the exam that you don't want to do that first, because that you may not be able to do any of the exam after that.
Right.
Yeah.
The exam enders, those parts of the exam where you've found something that's extremely painful.
Yeah.
So you have a patient that you suspect disease, or maybe in someone you expected, you anticipate finding advanced disease. Now, I imagine you're someone who operates on the bowel frequently. For those of us that, so I've got a colorectal surgeon, a colleague I work with regularly for patients in whom we suspect bowel involvement. What are additional tests you're ordering? Are all your patients getting ultrasounds? How frequently are you getting MRIs? What's your threshold for referring to colorectal surgery or urology for patients? What are next steps you take from clinic between your initial eval and then the operating room?
Right. So I would say majority of my patients don't end up with any further imaging, okay? And by the way, your typical OBGYN ultrasound are very, very insensitive with diagnosis of endometriosis, because most patients are going to have stage 1, 2 disease, and that's not visible on ultrasound, okay? And then so usually, if the patients have evidence of endometrioma, patient have like debris-filled cysts. For example, you're taking somebody out to do hysterectomy for fibroid, and you notice that she had debris-filled cysts, on her recent ultrasound, and you look 5 years back, and that the peripheral cyst was there already. Guess what that cyst could be? It could be endometrioma. So it's the worst thing that you want to do is going to do, you think a simple fibro endomyotics, hysterectomy for endomyosis, and you go in there and you have frozen pelvis. Okay. So presence of endometrioma is basically a factor, basically increase the risk of ablation of cul-de-sac, frozen pelvis, and bowel invasions by as much as 5 times, based on some of the earlier study by Ray White. Okay. So if I have a patient with endometrioma, I would order MRI, okay? Because my finger can only reach up so far on my exams. So if there are nodularities beyond the reach of my finger, I would miss it. So those patients with endometrioma, I would definitely order MRI.
You said you're not getting ultrasounds though on most patients, or you are?
No, most patients already have ultrasound by the time they come to see me, right? And then most of them would say normal ultrasound, right? But obviously if they come in with, the peripheral cyst or suspicious for endometrioma, regardless of my exams, those patients get an MRI just because the risk of having severe disease is so high.
Yeah, I order quite a few MRIs, a lot of them, and we've got a radiologist we work with closely here as well who, it's important to have, just like I think it's important to have surgeons who operate on endometriosis a lot. I think having radiology teams that are, used to looking at pathology is important. Do you have specific radiologists you work with regularly at UPMC that are reading your scans?
Sure. So the other indication for MRI would be if I feel nodules on exams. Then those patients get MRI. So there's basically 2 type of people get MRI: patient with endometrioma or patient with nodularities on exams. They get MRIs.
Would the third be the abdominal wall endometrioma?
Yeah, the patient is if I suspect abdominal endometriosis. I want to see what layers of the abdominal wall this endometriosis is involving, right? Because some of those patients might require resection of a segment of the rectus muscle. Some might have a piece of fascia removed that might require you to place a mesh. I place the mesh myself for a lot of those patients. I've been doing it for so many years. And so, so those kind of things you need to know. And then frequently, a lot of times, because if you don't know the depth of the invasions and you think that the endometriosis is just subcutaneous and you begin digging and you hit the fascia, most people just backed out and just say, stop right there. I don't want to do anymore. And then you end up with patients still have endometriosis on the rectus muscle, right? So it's important to know that information ahead of time. Just like, you want to know a patient had bowel endometriosis or bladder endometriosis, depending on, so usually, even in patients, I think that I can just do a discoid resections, okay, without doing the whole segmental resections, they will see my general surgeons regardless ahead of time.
Yeah, I do the same. And that's, I think those of us that are out there doing this without senior partners like you, I think as we've, developed these practice plans, it's always so reassuring to me. I think I was watching a video of one of our other colleagues when I was first out, and we're operating on a bladder nodule, and I thought, man, I'm just so far from being, in that level. And then I hear the person say, oh, and now as my urology colleague is going to take over. And it's like, okay, good. There's, I'm not the only person who's, using other people in the OR to help these patients get what they need. And I think, especially in academic centers, when you've got a colorectal surgeon next door and a urology on the other side, if you're doing that stuff as a gynecologist, you have to be pretty careful about whether you're going to be doing those surgeries with, when you've got the experts next door. But yeah, I've got a colorectal surgeon who I work very closely with, and on our advanced endo cases, if I suspect bowel endometriosis for the reasons you're talking about, I always have them go see them first. They oftentimes will get a colonoscopy if there's concern about transmural disease, and that way they're able to be counseled about what bowel surgery is going to look like. And so it's nice to hear that you also are referring to general surgery colleagues as well, just so I think it helps when they know the surgeons who are going to be involved on their team at the time.
Yeah, I mean, I do my discoid resection myself, and that's because I work very well with my general surgeons. So typically, if patient's disease is amenable to discoid resection, I do it myself. And then if the nodules is very large or it's multifocal, then they will come in to do segmental resection. So fortunately for me, I have I operate 3 days a week. Mondays I operate with one general surgeon, and Thursday I operate with different general surgeons. Okay, so they all have cases going on at the same time. Okay. And so they don't come in to do the surgery unless I told them that you need to come into the segmental resection. The discal resection, I just take care of myself. And so that's what I do. For bladder endometriosis, I do it myself. And then for uterine endometriosis, I usually do it myself with them watching me doing it for the most part.
For what was the last part? For the
uterine implantations, reconstructive surgery. One of the most recent cases,
because you're doing it all straight stick. A lot of urologists are robot only.
I'm their Da Vinci, basically.
I was closing a cuff one time because we had the urologist came in to look at something. I was like, oh, let me just close it real quick so they can get it and do their part. Yeah. And I hear the urology attending turn to his fellow and go, he's making it look really easy. Yeah, very easy. Because they're not doing a ton of straight stick stuff in urology. Yeah. But and again, I think it's not necessarily should or shouldn't you be doing things yourself. And I also, if there's a bladder issue, I'll have the urologist come in, but I'll close it myself. But I think the key is understanding what your comfort level is, getting to a point that you got to where you are now. I'm guessing took working with these other surgeons for years and years to get to where they know that you can handle these things on your own. You're not doing this fresh out.
No, I mean, I think it's I just feel very fortunate that I have all these people to rely on, when things gets beyond, what I can offer them, right? And also too is my general surgeons really trusts me. So, if they are stuck in their own case and want me to get started with their dissection for their segmental resections, I do all the dissections for them. I, lift the rectum, open the retrorectal space, tunnel between the eye and the ureter, get out all that space, dissect out for them. So when they come in, they can just do a segmental resection with the staplers.
How important it is for your patients and for those of us that do this to develop those relationships. And that's something that I don't know that I thought about ahead of time, but, over the years, I've got colleagues that I consider friends who I've operated with countless times and who, like you said, there's times when they pop in, they go, looks like you got it. And we do those parts or whatever. But yeah, I mean, over time, surgery is a team sport. And as we get further and further along, there's more and more people that are responsible for my training and my growth in those things. And so it's such an important part of this job is to have good colleagues.
But, on the flip side of the coin, the gynecologist for endometriosis surgery, the gynecologist should be the captain in terms of what needs to be removed. Okay. Because the general surgeon doesn't know what needs to be removed, so it's important. That's a great point. Right. So it's important for you to be able to, for example, if you just have the general surgeon coming in to do the bowel endometriosis and you leave all the endometriosis on the rectovaginal septum, retrocervical region, which is in the same patient with bowel endometriosis, they have a lot of endometriosis, behind the cervix, causing the uterus to wrap onto itself, right? The uterus can wrap onto a ball and then stuck to the cervix. And when you unravel that between the uterus and the cervix is all this disease that needs to be removed. The general surgeons are not going to do that. You are the one who is going to recognize that and take care of those endometriosis. You are responsible for separating the bowel from the posterior vagina and just say, okay, here is a huge nodule, or this is a multifocal nodule, or this is a patient with a stricture. You need to come in and do the segmental resections. You're the one who should decide if this should be a segmental or discoid. And that's kind of like my take on that.
And we'll have to have you back on the show to talk through the surgical side of things too, because it's so tempting for me to just keep going with this thread. But I want to make sure, for the purposes of this show, that we make sure we touch on all the ambulatory stuff too. But the other thing I was thinking about in ambulatory workup is the non-pelvic endometriosis. Like, what are your, I think we see occasional videos in our societies about diaphragmatic stripping and those things. What's your threshold for referring to or getting CT surgery involved for these particular cases?
Yeah.
How often are you finding diaphragmatic disease?
Yeah. So the people who I work with, the two general surgeons I work with also are surgical oncologists.
Oh, so they're comfortable in that space.
Yeah. So both of them are surgical oncologists and the bariatric surgery. They all that they do 2 fellowships. Both of them. So so for diaphragmatic I work with them, and then they would just, they'll help me position the patients. And then frequently a lot of diaphragmatic the best position would be left lateral to keep it this position, because you use gravity to retract the liver out of the way and give you a good exposure to the posterior diaphragm.
So are you repositioning them intra-op?
No, usually I don't like to do them in the same settings. It just,
Oh, so separate surgery.
Yeah, because a lot of times you don't really know like how bad the diaphragmatic endometriosis, and the imaging is not always that great for diaphragmatic endometriosis. So I tell the patients that usually it's just better to do like a stage procedure if you have diaphragmatic endometriosis, just to know exactly where the disease is and everything. Okay, because not all diaphragmatic endometriosis is the same. Because if you have diaphragmatic endometriosis near the central tendon, that's much more dangerous, because that's where
it all sounds dangerous to me.
No, it's because near the central tendon, that's where all the the vena cava, the aorta, the portal vein, all the phrenic nerve is in the central portion of the diaphragm. And
what's the clinical findings where you're suspecting that? I mean, what gets you to the point in the clinic, in the office, to where you suspect endometriosis in those spaces?
Well,
there's
cyclic, chest pain or shoulder pain. They will tell you that, and there's not many things that can cause that. So the thing is, the problem is that when I tell a patient I'll put additional port under the rib for me to reach that area, to be able to visualize, I put my scope, my camera underneath the rib to look around the liver. If you keep your umbilical trocar as your primary visual port for diaphragmatic endometriosis, you'll miss a lot.
And so you'll see it, you'll diagnose it, and then you'll wake them up and talk to them about it, and then come back another day to manage if you do find it.
Exactly, yeah. And actually, a lot of patients don't have it.
Right, but you won't know if you don't look.
Exactly, yeah. So if you just say, okay, I look at it from my umbilical port, you may miss it. If you really want to know, you have to put a subcostal port there.
I do a lot of Palmer's point entry as well. So
so like on the right side, if you do that on the right side and look around and use the angle scope to look around the liver, then you'll find it.
Excellent.
Most of posterior diaphragmatic endometriosis, you're not going to find it with umbilical port.
Right.
Yeah.
That's interesting. It's helpful.
Yeah.
So in the clinic setting, anything else we're getting close to time here. I know you're a busy guy.
Yeah.
Any other imaging studies, lab tests, anything else you're getting in these folks? Because I think that's sort of what I think of as in terms of my workup. But anything else we're missing that our listeners should think about when evaluating patients for endometriosis?
Yeah, I think a lot of your listeners are OBGYN, general OBGYN in the community. One of the worst things you could do is order CA-125 and then it's elevated and refer to oncologist. You're guaranteed.
It's always going to be mildly elevated with endo, and it's just going to
it can be also pretty high too. So what's going to happen is the oncologist is going to remove that patient's ovary, and that's what's going to happen. You are basically asking the oncologist to remove the ovary when you do that. So so in young patients, I don't typically order any tests. Obviously, it can be elevated in the patient with severe endometriosis, but there are a lot of the newer tests that's coming in the horizon.
Yeah, so let's talk about the future of diagnosis of endometriosis. So there's a study in the lay press about a Japanese study, which I'm sure you heard about, with the Fusobacterium, I think, was found more commonly in the uterine microbiome in patients that had endometriosis compared to those that don't. Again, very, very early. It's one study, not a huge number of patients. But what do you think the future of endometriosis diagnosis looks like?
Well, I think it's already here. I don't know if you have heard about it, but there is a company from France using the same technology that was used to discover the COVID vaccinations, the microRNA. They were able to find like a little bit over 100 signature microRNAs for endometriosis, and are able to achieve like close to like 97% sensitivity and close to 100% specificity. Basically,
this
perfect
is just
test.
A blood test.
No, saliva.
Oh, come on. Really?
Yeah.
Is this to market in Europe, or this is like early?
I think they are pretty far. I mean, I first heard about this when I attended the ESG in Lisbon last October.
Oh, so a while back, like 8 months ago? I mean, not a while, not years, but like within the last 12 months.
Yeah. I mean, you can Google it. You'll find those studies.
Yeah.
And it's pretty amazing. And so the problem with that, I actually was playing around with ChatGPT the other day, and I asked what would be like the pitfall of extremely sensitive and accurate diagnostic tests for endometriosis. And ChatGPT gave me incredible answers.
Better than any student, resident, fellow, or faculty member, probably. Yeah. What did ChatGPT have to say?
ChatGPT says that you're going to have a lot of patients who are overdiagnosed and overtreated. Okay.
Because you're going to have asymptomatic patients that are going to have it, right?
For example, we all know we have patients who have like kind of incidental endometriosis, very small superficial endometriosis. You're not even sure if that's the reason for their pain, but you excised and you diagnosed it. Sometimes endometriosis can be incidental, have nothing to do with the patient's pain, right? But it's very hard to persuade the patient that endometriosis may not be the reason for their pain, because they have a diagnosis and nobody give any reason for their pain for the past 10 years. And now they say, well, I have biopsy-proven endometriosis, even though with just a little bit.
Or mRNA diagnosed endometriosis, not even biopsy-proven. Yeah,
Exactly, because it's so accurate, right? So now you're going to have this, you can test the saliva, and then you have all the patients diagnosed with endometriosis, and they all think that the reason for their pain is, endometriosis. So there's going to be, what you do with the information is going to be like the challenge, right? And ChatGPT predicted that, by the way. I asked them the questions. Okay. Access. ChatGPT talking about access to, because the test may be very expensive. So if you don't have money, you don't have the right insurance, you may not be diagnosed. So there could be some inequity.
Unnecessary surgeries,
over surgery, over treatment, right? Or over medications, right?
Over medicate. That's right.
Right. So so it's not, even though you have like the most perfect test, it create new problems.
Be careful what you look for. So be careful
what you wish for. Right. Exactly.
Be careful what you look for, because you just might find it. And then now what do we do with that information? Like, okay, we have this thing.
Right.
We don't know what it means. You can worry about it forever, or we can expose you to a new risk from a different intervention. So yeah, well, it's exciting. I mean, I think there is more interest in endometriosis than there's been in our lifetime. A lot of that has to do with you, both in your work as president of AGL, and your video work, and your work with, we didn't even talk about your work with the health economic stuff, with the ICD-9 codes and all those things. I mean, your contribution to medicine, to women's health, to endometriosis is massive, Ted. And it's
thank you.
You make a lot of us feel. You make a lot of us feel like we're not doing anything compared to how much you've contributed. But it is great to call you a colleague and a friend and a mentor, someone who I look up to very much. And I definitely and all your fellows you've trained. I mean, you put out unbelievably well trained fellows, and you've really done an amazing job in your career. Not that you're done, but just to see what you've done so far is incredible. So it means a great deal that you've taken the time to join us on BackTable, and we'll definitely have to have you back on at some point to really get down to the nitty-gritty in the operating room and the surgical side of all this stuff.
Well, great talking with you. It's been a pleasure and honor to be part of the podcast.
Well, thanks again. All right. Well, good catching up, and hopefully we'll get to hang out soon. And one of these days I'll have to convince you to take me fly fishing.
Very good. Thank you.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our audio team is led by Kieran Gannon, with support from
Josh McWhirter, Aaron Bowles, Nick Shellcross,
and Ness Smith-Savadoff.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon Hess and Yvonne Overjinsky.
Show notes and social media by Jody Lenora.
Administrative support provided by Jamila Kennebrew.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any entities they represent.